I love it when I meet, family, so, new patient, and I'm doing my history, and it's anyone in your family ever have mental health problem? Oh no. And then the next week, well, I talked to my aunt so and so, and she said that, and then all of this is like, okay, there's a dozen people in my family have had problems. So because simply people don't talk about it, and so and of course, like it's not all that you need to see a professional, right? There's a whole level of care and things that people can do to help themselves and so on. But the fact is, I think the biggest point is that one has to recognize that there's something just not right.
You're listening to the Health Disparities Podcast from Movement is Life. I'm Hadia Green, your host for today's episode. I'm a steering committee member of the Movement is Life, a doctor of physical therapy, and founder and president of Healthy Healing Community. Today, we'll be talking about mental health. Mental health is an important part of our overall health. And just as there are disparities when it comes to physical health, disparities are prevalent as well when it comes to mental health. Many factors contribute to these disparities in mental health care. Fortunately, there are people out there working to advance health equity when it comes to mental health and to close the health disparity gaps. Dr. David Henderson, who is with us today, is one of them. He's a psychiatrist and the chief of psychiatry at Boston Medical Center. Dr. Henderson, welcome to the Health Disparities Podcast, and thank you so much for being here.
Well, thank you for inviting me. This is wonderful to be with you today.
Excellent. Dr. Henderson, let's jump right into our questions for today. Tell us about the work you do as a psychiatrist in chief at Boston Medical Center, or BMC, and as chair of psychiatry at the Boston Medical School. You please include that, some information about you leading a program at BMC called BEST, which, as I understand, stands for Boston Emergency Services Team.
That's right. Well, thank you. Yes, so I head up the Department of Psychiatry here at BMC and BU, and so it's my job to make sure we have the resources and the people to care for our people in our community. And as you know, Boston Medical Center is a large safety net hospital that we treat anyone who walks through the doors. So we have to have a pretty large capacity in order to care for the community. And so I've been here at BMC for about 8 years. Prior to that, I was at Mass General Hospital, and the two institutions are very different. But I would say that we really had to pretty much, quadruple our capacity because the need for mental health is so great. And speaking of disparities, there's just such a gap in availability of mental health care, throughout the world, really. So it's my job to help build capacity so that we can meet the needs of our community.
Thank you. Dr. Henderson, can you talk about how BEST specifically is disrupting traditional health and mental health care models?
Well, the BEST program, it's our emergency services program. And so it's been in operation for more than 20 years now. And it basically started with a mobile crisis unit. And so there's a phone number that people can call. And originally it was funded by the Medicaid insurance as a service for the community. And so anyway, people can call this number and speak to a clinician. Clinician determines whether they should go out and do a home visit or whether there should be another type of intervention, including getting the police involved and bringing the person to the emergency room and that sort of stuff. So it it has been pretty amazing because the program started with simply just this, and then it has evolved into numerous other programs that are connected that really allow us to kind of fill in the continuum of care, so that in many places, in many communities, they do one slice of it, but then there's nothing else. And so we over the course of the 20 years have built other programs that help kind of fill all of the gaps, so that people get the care that they need when they need it, and the in the least restrictive environment as well. So it's been I think quite a journey, and for me as a researcher, um, my role, because I didn't start BEST, it was here when I arrived, but my role was to um, really take a look at the data and to see how what we can learn from the data. We looked at, like, we had 80,000 lives in acute distress over the course of 15, 16 years. And I felt that we could learn from our patients. And so we started using the data to teach us to make better decisions or to develop new programs and so on. So I think that's actually critically important as well.
You mentioned the police. What can you tell us about some of the access points to BEST? In other words, how would I, if I'm someone in the community, even know that BEST exists? So how is that information disseminated, or how does one come in contact with BEST? And secondarily, can you name some of the types of members that make up the BEST team?
I'm sorry, type of members that make up the BEST team?
And by members, I mean actual the people on the
The clinicians?
ground level who are helping. So is it a psychiatrist, a social worker,
Okay.
police, those type of
Okay.
people?
Okay.
Mhm.
Yeah, so the first is the best team is the clinicians are primarily master's level clinicians who are backed up by a psychiatrist. We have a psychiatrist on call, 24 hours a day, 7 days a week. And master level clinicians are usually social workers or licensed mental health counselors. And they do the majority of the work and evaluations, and then they have a consultation with the psychiatrist. So that's one piece I think is it's really important. Many other programs around the country, they don't provide the psychiatrist as a backup, and so there are some challenges there as well. And so working with the police, and particularly, because we work in several communities, not just Boston, but Boston is certainly one of our main partners. We first started, simply by, when again, somebody calls, the information is readily available. It's publicized to the Department of Mental Health, and every hospital knows that this is the number to call when they want somebody evaluated. And so there's a number of options. Like, somebody calls and says, I'm having a problem and that sort of stuff. Sometimes we can just send a clinician out to their home and evaluate them. Sometimes they go to the shelter or wherever they are. When it's determined that they may need a level of care, particularly an evaluation in the hospital, in an emergency room, and then in Massachusetts, we have what we call a Section 12, and that gives, the doctor, signs it and says, I'd like this person brought to the emergency room so they can be evaluated. Doesn't commit them to anything other than to that evaluation. And typically those are executed oftentimes by police, sometimes by ambulance, EMS system. Now, as our program has evolved, the system has changed. For instance, we for years we've had 3 clinicians in the Boston Police Department, and the clinicians would ride out with the police on calls that they thought were appropriate for there's a question of a mental health crisis associated with the call. So our clinician would ride out with police, and then help determine, working with the police officers, what's the best intervention. And so so we had three, and then around the time of the George Floyd tragedy, and everybody wanted to do something and so on. The city of Boston came to us and said, okay, we want one of your clinicians in every precinct. And so we went from 3 to 20 clinicians. So every police precinct in Boston has a clinician that goes along with the police officers when there's a question about mental health. And this has, I think, had a significant impact in decision making. And so, for instance, we can, one of the major issues that we're concerned about is that many of our patients end up in jails, arrested for various usually minor offenses and so on. But with our program, called the co-responder program, we're able to kind of help come as a tool for the police officers so that they can make different decisions, and lead to different outcomes. So we've been able to show that we've reduced arrest rates significantly, utilizing these programs. And so it's been a wonderful partnership. And when it first started, the police officers were really reluctant to have a civilian in the car with them, and now they're asking for it. They're like, oh, can I have the clinician with me today? So we really were able to change the attitudes, and as the system evolved. And so for every Section 12 that the police will execute, now they go out with one of our clinicians. So it's been really great to see.
Well, you are leading me into the two things that I wanted to talk to you about, namely access as well as the criminalization part. But let's start with access first. So when we talk about mental health access to care, what would you say are some of the disparities that persist in our nation when it comes to mental health?
Yeah, access remains a huge problem in this country, and in even in some communities. Now, the funny story is I tell people that in Boston, you can't walk down the street without passing a psychiatrist every block. There's so many of us here, right? However, it's hard to staff our hospitals and our community health centers and so on, because of the large population is in private practice. And so giving access to those who can afford it, but for others who have to rely on insurance, government insurance, or even commercial insurance, the access is really difficult. We wake up, and like we've got 2,000 people on our waiting list that we have to try to get to see, and so on. And so it's a challenge here. Now, I have a different perspective, however, because I do global work, and I've worked in countries where there are no psychiatrists or one psychiatrist and no other kind of clinician level specialists around mental health and stuff. And so that's a challenge. That's a different type of challenge. But we really have to work hard to improve access. And of course, it cuts across the disparity line and the racial line, and so on. And so, many of our, Black and Brown communities are underserved when it comes to mental health. And so our goal is to be able to bring access as best we can to our patients.
Thank you. And as far as caring for those marginalized communities, like you started to allude to, that don't have the same access to mental health care, including people living with schizophrenia, and other serious mental illness. You have experience working both locally and internationally, as you mentioned, in resource limited areas and communities impacted by mass violence and disasters.
Uh,
What kind of things make it particularly challenging to reach these groups? You touched on some of it being almost insurance or cost impacted. What other things, or if you'd like to go further in depth on that, would you say?
sure, thank you. Yeah, every place and country and state or city, their problems are different, and the challenges are different. And so, I think that for me, my global work has put things into perspective for me. In that, when I'm in Boston and people saying we have no resources, and I just kind of laugh because they have not seen what it's really like to have no resources. And so when I'm working in a country like Liberia, where for many years there was just one psychiatrist for the whole country, um, it it's so the question is how does one care for people when number one they had been through 18, 20 years of violence with a war, so they're post conflict. um, uh, so that's one group of people who are affected, right? And then they have the typical, like those with serious mental illness like schizophrenia and so on. And 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 but they still have to be able to provide some care. And so for me, it's really thinking of the long game, in that, let's, yeah, what we can do something today, but what can we do tomorrow that's going to change the course of this situation. So for Liberia, for instance, we got involved in 2009 and helped the Ministry of Health write the mental health policy for the country, but that really didn't change the mental health care. It was just a piece of paper. But finally, we were able to work with the one Liberian psychiatrist, Dr. Ben Harris, and we started a psychiatry residency training program in Liberia. So we've been training Liberian doctors to be psychiatrists. And we utilize some of our partners. For instance, we'd send them to Nigeria to get substance use training, and so on. And our team in Boston would supplement the teaching on the ground, and we would travel periodically as well. And so now in September, we will graduate two more. And so we've already graduated four doctors who are now psychiatrists in Liberia, and we'll get to six in September. And these doctors are now taking over the mental health system for the country. They're in the Ministry of Health, and so on there. And so just by doing that, I think we dramatically changed the outlook for that country. Where I met with the president of the country before many times, and oh yes, we need help with mental health, but actually they weren't ready to do it. And so we just waited them out, and then finally the government supported the training program, and now they have specialists who will build their mental health system. And so that's just one example of how we figure out where we're at and then how to improve that system. And we do the same thing in Boston as well.
I love that you mentioned that differences or disparities is different depending on where you're at, and what we might perceive as a lack of resources is relative to where we are, and that if we haven't seen what nothing actually
Yeah,
looks like. And so maybe you can touch on this integrated mental health care model, specifically best, and how it plays a role in addressing mental health disparities and what that means to you, and what it looks like in practice.
yeah, thank you. That's great. Um, and to get back to your comment about the criminal justice system, I think this is a critical piece to this story, because everybody's heard of the deinstitutionalization of people with mental illness decades ago, um, pushing people out into the communities, even though the community system was poorly set up in order to really care for individuals and so on. And so the criminal justice system has, by default, be, become one of the largest mental health systems in certainly in Massachusetts, but I think around the country as well. Meaning that people with mental illness are in jails and prisons at a percentage that really should not be. And so one of the challenges is to, like, how do we address that as well? And so Best started with the emergency services and the kind of the mobile unit, and then we added the police ride along, and then we started working with the courts and established mental health and substance use courts so that we could try to prevent people from having to go to jail. Um, and then which I think it's a critical piece, and then we added an outpatient assisted treatment program that allows people coming out of jails to immediately get connected to mental health and healthcare, because we know that the data has shown that when you come out of jail, if you don't get connected to healthcare within a month, you end up back in jail. So there's very clear data. So we get them immediately and connect them. Now, I'll have to tell you a little story. I love to tell stories, but during the George Floyd thing,
Mm-hmm.
Everybody was calling me. I don't know why they were calling me. They go, "Hey, Dave, what do we do?" And I'm like, "I have no idea. Like, tell the police stop doing it." That's all I could think of. But and then I had an experience that really brought a new level of insight to me and a new idea. So I was, it was during the pandemic, and I was like at a grocery store at the town next to me. As I came out with my groceries and I got to my car, was loading the groceries in the trunk, I saw that there was a police officer in a police car with lights flaring and had pulled over a young white male, and he was searching this young man's car. And then I saw that he must have called for backup because another police car was coming into the parking lot and had a direct line towards where the other police car was, and this young man was directly driving towards it, and then somehow saw me at my car putting my groceries in the car and deviated and pulled up right next to me, even though like the police car is over there, like how you couldn't miss it, the lights are flaring and so on. And I thought to myself, well, how powerful is that? Right? How, like, that's like your brain is you're headed right for the danger, and your brain is telling you, no, 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 there's a black man over there, that's where your danger is. And I thought, man, that's absolutely amazing. So I just processed it, like the police officer looked at me, I looked at him, like, I'm sure I was thinking some not so great things. And he went around and went to the other police car. And then that night, I woke up at 3 a.m, and I said, I got it. Because everybody's asking, how can we have an impact with and prevent the George Floyds again and that sort of stuff. And I said, wait a minute. We have the relationships, the best program. We're in the community, working with community organizations. We're working with the police. We're working with the courts. We're working, in the schools and so on. So we actually have the right partners in the room. We just simply have to shift what we do and how we do it. And so from that, we decided that we needed to add a kind of racial and social justice piece to it. And so when we train the police, we need to bring that content into it. We're lucky at BMC, we have a multicultural psychology program that's been in existence for 50 years. Teaches people how to, understand their own, biases and how it impacts decisions and that sort of stuff. And so we're starting to bring all of those things into everything that we do in this really comprehensive program that touches just about every data point.
You've talked about some of the pieces of having a vicious cycle between unmet healthy needs and people and recidivism and going in and out of the criminal system. And you've also touched on the importance of community-based options for treatment so that there's actually that careover so people don't end up back in the system or at least untreated. This makes me think about trauma-informed care in general, another word that seems growing in people's knowledge, even though it's something that has existed for quite some time. It seems that more clinicians, not just who are trained specifically in health, mental health, are trying to infuse this um, method or knowledge into their care. What does it mean to provide mental health care that's truly trauma informed?
Thank you. I think this is an important area. I think first is to recognize that everybody has a history and everybody has had experiences, and some of those experiences could be good, and some of those experiences could be bad. Um, and 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 particularly as it relates to healthcare, for instance, in Black and Brown populations, depending on the where they get their healthcare and so on, it has a big impact on how well they feel they're treated, and so on. Do they feel welcomed in the environment as well? Now, at Boston Medical Center, because of the population that we care for, we are always thinking about trauma and trauma exposure, and therefore, how do we present ourselves to patients and the communities with the understanding that many folks have been exposed to various types of traumatic events, and those traumatic events are often with them every day, and they have multiple exposures and so on. So for us, it's important for us to be aware of this, and then to like just training people on how to greet people, how to deal with somebody who's upset, how to recognize that. Like every time we do a survey, we see that the percentage of individuals who have experienced traumatic events, and even like in my global work, I'm not a big PTSD person, in that or post-traumatic stress disorder, because I don't think post-traumatic stress disorder captures everything that happens when somebody has a traumatic event. And so it's one thing. I think it's one outcome of trauma, but it's not all encompassing. Um, and so for us, it's really, we have to integrate everything that we do with the mindset that this could be in somebody who's had traumatic experience. So how would we do that differently? How would we interact with them differently? How would we even set up our waiting room, and where they can exits, all sorts of stuff at all levels. And I think it's absolutely critical.
You've mentioned throughout the talk the George Floyd tragedy, and we know in this country that George Floyd is not um, it's not unique. Um, it happened during the pandemic time when everyone had to sit down and be still.
That's
And
right.
it was so much more in our faces. And we're in an era of technology where things are televised and easily information is more easily disseminated, right? It was the perfect storm of time for people to actually receive and in this case feel what happened. But being that these disparities in life existence in the US, I'll speak to specifically. Um, is there some shining light on mental health and mental health disparities, um, even if there's some exacerbating of mental health conditions in number that happen, a cause to the pandemic? And in your expert opinion, would you say that we're still recovering that? Or is there a silver lining? Do you think there's a heightened sense of awareness among healthcare professionals and or lay people about the importance of mental health care?
Yeah, I think, thank you. I think that um, coming out of the pandemic, and you're right about George Floyd like situations. It's been going on forever, right? This is, but the attention I think given to it, I think, brought us to a new level, I think, of focus. But with and the pandemic itself, simply because it created a whole new population of people with mental health problems that we still have not addressed or to have the capacity to do so. Um, I've spoken to many people recently who have mentioned the fact that they feel that like they are certainly have been more aware about mental illness now, and even and more open to talking about it. And as stigma is huge across many cultures and populations and countries. Um, and so there seems to be, as a result of the pandemic and the exposures and stuff, that people we're at a place where people are more willing to talk openly about mental illness, get help for their mental health problems, and so on. So I hope that this continues. As many times these things get hot and then they just cool off and disappear, and we go back to where we were and stuff. But my hope is that the attention around mental health really needs to stay in the light, because quite simply, everybody's affected by it. Every family has been impacted. You can't go, like, I love it when I meet, families, new patient, and I'm doing my history, and it's anyone in your family ever have mental health problem? Oh no, oh no. And then the next week, well, I talked to my aunt so and so, and she said that, and then all of this is like, okay, there's a dozen people in my family have had problems. So because simply people don't talk about it. And so, and of course, like, it's not all that you need to see a professional, right? There's a whole level of care and things that people can do to help themselves and so on. But the fact is, I think the biggest point is that one has to recognize that, there's something just not right. Um,
Thank you. So BEST, the Boston Emergency Services Team, has been a trailblazer in mental health crisis intervention for over 20 years. And you mentioned in the care that BEST delivers, acknowledging that we all have our biases, even healthcare professionals. And so one term that people are familiar with is being culturally competent or culturally competent care, which may suggest to some people, but that there's an end to becoming culturally competent. There could be some confusion about what it means and how it plays out. Tell us from your perspective what culturally competent mental health care looks like for teams that you lead.
Well, I almost laughed, but because I don't believe in the term cultural competence, because I don't think it exists. I'm African American. I don't even think I'm culturally competent in my own community, because there's such variety and differences and that sort of stuff. I couldn't say that I could speak for African Americans and so on. So, but I do recognize that cultural sensitivity, to build the ability to recognize and value others' cultures and differences, I think is absolutely critical. Now at Boston Medical Center, my challenge is, and I tell this to all of our trainees, is that, like, how do you develop a mental health system that cares for people from 70 different countries every day? So people from 70 different countries every day come to the hospital. How do you develop a system for that? Keep in mind, like when they were back in their country, like in Ethiopia, like if they had to go to the doctor, like they'd pack up the family, they'd pack up some food and water, and they'd go to the doctor, and they expect to just spend their whole day, and they would just be there with the family until it's their turn to be called, and so on. And we here at Boston Medical Center would say, okay, you have a 9:10 appointment, and if you're 10 minutes late, you cannot be seen. And so we have to be adaptive to people's, histories and culture and so on, and try to understand, like, how do they best engage with the health system, and then also, like, how does their culture influence their illness, and their, when they seek treatment, where they seek treatment, all of that stuff. So for me, it's a lifelong process of learning, but it comes with, the basic is that being respectful and curious about another human being, right? And where they're from, what their history is, and how did they get here, and what do they think about this? So asking our patients, like, what do you think about this? Like, how do you explain it? Because I have my explanation, which oftentimes is completely wrong, or different from their explanation. So anyway, so I think there's a process of being, clinicians can get to cultural sensitivity, and learn from each and every patient, and take that information and apply it to their care. Maybe even change the system if there's, tremendous insights and stuff. And so I'm a supporter of that. Like, for folks who say they're culturally competent, I usually just like to shake their hand, because, because I've never could say that I'm culturally competent.
Right. So we have with you, Dr. Henderson, had the pleasure of crossing over several topics under mental health, and specifically as it relates to BEST, that emphasizes culturally sensitive and trauma-informed practices. Is there anything that you'd care to elaborate on, that this approach and how it supports marginalized communities, or any topics that we didn't have an opportunity to touch on in our last minute or so?
Well, I'll just say that I want to mention some of our global work, because really at Boston Medical Center, we established a global and local program. And the reason for that was because, like many of the countries we were working in, we had patients from those countries coming to our hospital. And so the learning was bi-directional. So we learned some things in Boston, we take it over there. We learn some things in these countries, and we bring it to Boston, and implement it. But one of the best things that we've done is to we established this organization called the Africa Global Mental Health Institute. And what it is it's designed to bring together mental health leaders and clinicians from 25 different countries in Africa and the diaspora, to improve the care for African descended people, the mental health care. And so what it is that we've got these countries now working together, sharing resources. For instance, if you want to start a program, like we did in Liberia and Hargeisa, Somaliland, to train doctors to become psychiatrists. And there was no doctors in the country. We relied on our partners, like in Ethiopia and Nigeria and so on, to help us train them. And so it's getting people to work together around clinical care, research, education and training, and policy and advocacy. And we're in our 8th year, and it's remarkable, because as I tell people, like, we're out of time. We're out of time, and we really have to accelerate the capacity building for to provide mental health care globally, and particularly in the African diaspora, because the care for these populations is lagging way behind, and so we're out of time.
And unfortunately, I could talk to you about this for hours, I am sure, but we are too out of time. I am very appreciative that you mentioned that there is a school, so there is a way and programming that people outside of Boston Medical Center can actually either contact the center or contact you so that they can replicate in a way that is sensitive to their own communities and meeting their mental health care needs. You can learn more about the Boston Medical Center's BEST program at the link in our show notes. I'd like to thank and honor my guest, Dr. David Henderson, for joining us today. Thanks for being with us.
Thank you. It's been a wonderful opportunity for me to be here with you today. Thank you.
That brings us to the end of another episode of the Health Disparities Podcast, a program of Movement is Life, which is a nonprofit organization committed to advancing health equity. If you'd like to hear or you'd like what you hear, be sure to subscribe wherever you get your podcast and take a moment to leave us a rating. It really makes a difference. I'm Hadia Green. Until next time, be safe and be well.